I think to maybe put my own slant on this, is it shared decision making? I'll just be a little bit devil's advocate here. Shared decision making sounds really good, but is it possible? Because, I mean, just for example, the patient is in a different position in many, many ways from the clinician, which makes the ground uneven. It's not a level playing field, cliche. Can we do shared decision making, or is it a bit of an illusion or an aspiration that we can't actually achieve? And that's to any panelist, or Ashok, if you want to come back on that.
Yeah, I think that the question that Mark has asked is a really good one. And maybe I can have a tiny bit of liberty to say, look, I used to say, before I got involved with Bill Fulford and the values-based practice movement 8 years ago, in fact, when I first met Bill and he was talking about it, I said, a bit like Marco, I said, look, I don't see the point of this. Much to my shame, I said that to Bill. And then over dinner, we were having dinner, I was thinking about it, and I said, well, look, you know, when I teach students and the way I practice and trainees is that I said there are only 3 types of decision to make. One is where there's really good evidence, overwhelming evidence, that a particular course of action has huge benefits for the patients, very little risk, and I can recommend that course of action or treatment to the patient. Now, the patient can still say, thank you very much, I don't want to have that. And I might then say to them, why do you say that? What are your reasons? And then that's into a dialogue. And not because I want to persuade them to have it, I want to make sure they've understood and hence have made a good decision for them. And that decision may be not what I'm recommending, but it'll be the right decision for them for whatever reason. There's a second other extreme where a patient might be seeking a particular course of action or treatment where the risks are really high, the benefits minimal, and the evidence is also against it, both the evidence and my expertise. In which case I say to the patient, I'm very sorry, but I'm not prepared to offer you this treatment. These are my reasons for not doing that. And you can usually tell if someone's unhappy with that. And if someone's unhappy, I'd say, I can see you're a bit unhappy with that. Would you like a second opinion from one of my colleagues? And at that point, I only had 4 colleagues in Oxford doing vascular surgery. And I said to say, you can have one, any of the 4, you choose. And then about 5 years ago, one of the patients said to me, well, you would say that, wouldn't you? And I said, what do you mean by that? And they said, well, they're all your friends, aren't they? They'll all say the same as you. And I said, whoa, stop. You know, I understand where you're coming from. You're right. They're my professional colleagues. I work closely with them. As it happens, only one of them is my friend, but that might tell you more about my working arrangements. So I've changed to say you can see any vascular surgeon in the whole of England and Wales, and I will facilitate referral. In the middle is a third type of decision where there are actually 3 or 4 courses of action, choices, each of them equally reasonable, good evidence base, risk benefits. And my job always used to be to give people the risks and benefit and say, look, you can have any of these, you choose, and I'll support in that decision. But as I said earlier, the vast majority of patients said, what would you do, doctor? And before getting involved with values-based practice shared decision-making, I would do exactly what you were suggesting earlier, David. I'd say, well, if I were you, Laura, for example, if it's varicose veins, I'd say, Laura, stockings for you, Stephanie, injections for you, David, no treatment for you, I'm afraid, and Verian's going to get surgery, okay? And that would be based on what I thought might be important to you. What I do now, and this is the switch, Marco, is I say, okay, it's interesting you to ask me that. Why don't you tell me what sorts of things are important to you? And then together we can pick which of these options might suit you. Now, it does take a little bit longer to have that conversation, but it means you do get shared decision-making. And the great thing in healthcare about shared decision-making is, one, the patients are much more likely to follow through with the treatment and follow all of the post-procedure and extra care. They're involved in that decision, they're committed to it, but also they share the outcome. So there are no recriminations afterwards because they made that decision and they know they made that choice. So Marco, I think you can do it. It really is different. It takes a little bit more work in the clinic to do it, but you don't have to deal with any complaints.
Yeah, thank you, Ashok. That's great. Okay.
Can I jump in here, David? I think totally agree with Ashok. Isn't Montgomery about commitment to dialogue? And that, giving that space in the clinical encounter to have real dialogue, to understand both the clinician and the patient. I think shared decision making is possible. I think it's, as Ashok said, through shared decision making, you have shared responsibility and shared ownership, and a commitment to follow through on treatment and outcomes. So I do think shared decision making is possible. I think there's huge challenges from management in terms of understanding what that involves and allowing the right time for proper consultations. It also requires the clinician to be fresh in terms of having the emotional focus and energy to incorporate that in their practice, giving that the right space. And in the end, what the clinician is wanting is the best outcome for their patient, as well as the patient wanting the best outcome. So it's altering the focus, it's altering the perspective, and shared decision-making is about partnership and how you facilitate through communication that journey, and actually the importance of valuing that. Thanks.
Thank you, that's excellent. Have we got, okay, anybody else want to come in at this stage with comments on what Ashok said or what Varian said?
I was going to say me, but Stephanie, please.
Stephanie. Where's Stephanie gone?
I'm here. Thank you. Yes, I really like some of the points that Ashok and Varian raised. I think going back to that way of engaging with the person, if you can build that relational aspect first, you know, when that person comes into that encounter, you know, it just takes, I think, just almost a couple of nanoseconds to realize if that clinician or that person is truly present for them. And I think that's an art. It's very, very important to cultivate, that you are truly present there as that person-to-person encounter rather than with the clinical gaze, which is very important to come. And I think maybe people do want certainty in their diagnosis, but realistically that's not possible sometimes. But what is it in that encounter that very important question is about what is important to you, what matters to you. And I suppose I'm thinking of certain settings where that's not so easy for clinicians to enable to happen for a person. And I know we're talking about George here in a very specific aspect, but I'm thinking when you work in areas of psychiatry, you're often very restricted at a point in time as to what is possible to collaborate with the person. And that always requires that careful thought and dialogue. But just coming back to George, ultimately, in terms of Laura's helpful information, that George had already made this decision, but it would have been, I think, that encounter with George, if the clinician could have identified that, you know, as a starting point. But then ultimately, what's important to you, George? What do you want to be able to do in your daily life that is going to enable you to do this? And how can we collaborate in order to get an outcome that is going to help you achieve that? And then obviously the clinician has their diagnostic clinical reasoning hat on, but you know, where the person is coming from is going to be a different perspective. And I think ultimately people can have the most sophisticated procedures in the world. It can be state of the art, but ultimately what they want to do is pick up the threads of their daily life following that. And that's always, isn't it, what we as humans want, is to make some sense and meaning and purpose in our life, and how we can, you know, who comes into our life at certain points when we're ill, or, you know, our life, you know, we feel a bit broken, but who comes in on that journey with us and helps us make sense of that becomes ultimately so important in values.
Absolutely. Not quite sure which to take next? There's a sort of general question that, I'm sorry, the thread just disappears on my screen, but from Geraldine Finnan, it's been up there a little while. It's about, because you can't have the loved ones in the consultation, does that make a difference? Has that altered the way clinicians communicate with patients?
Maybe I can pick that up first, David. And I think, Geraldine, thank you. It's a really good question. And I think there are some things that have got better because of it and some things that are worse. And in fact, we've launched a Digital Health and Innovation Network as part of the Collaborating Centre, because we're quite worried about that and how to address it. And Mihir, who's doing the admin today, is one of the co-leads for that, just to promote that network. So on the good side with COVID, I think it has changed it. So one thing is that a lot of that communication has ended up being directly to the patients. You know, the clinicians will pick up the phone or arrange a Zoom call or a Teams call or other platform, rather than go via what I call the gatekeepers, who are the general practitioners. So I think that's meant that that's a better thing, direct communication with the patient. Also, it's meant that a lot of the time, people don't have to wait as long for results. The results come in of investigations, and the clinicians will pick up the phone and talk directly to the patient results. So that's speeded up thing, and has also reduced quite a lot of unnecessary visits to the hospital just to go and find someone, meet someone with a result, or to tell them that everything is great after your procedure, or your treatment has worked. And when you can do that on the phone. So I think that those are all the positives of what COVID has done by reducing footfall in the hospital, reducing unnecessary journeys, and actually it'll help climate change too. So there's some fringe benefits of that. The downside is that sometimes that communication is not as good as being in the room with somebody, and also in the room having your loved ones or your carer or a friend with you, because two heads are definitely better than one. And so I think that's a downside. The other downside is that there is a very important aspect to that face-to-face meeting, including clinical or physical examination. And you can't always get that across Zoom or Teams. And the third thing is that lots of healthcare organizations, and includes private care, I'm afraid, have used COVID as an excuse to restrict and block access to healthcare. So I think those are the downsides, and we need to fix that as a healthcare system.
What is the patient's responsibility? So we've heard a lot about how the clinicians need to be more compassionate, need to be more aware of the uniqueness of the person involved, etc., etc. To what extent, given that it's shared decision making, it's emphasizing the shared, to what extent does the patient have a responsibility? So, for example, in George's case, should he have gone straight in and said, I haven't made my mind up? Question to anybody.
I think it's a process. They're engaged, the clinician and the patient are engaging in a process. And communication and understanding is key. If you follow the line from communication, good communication would facilitate engagement, would facilitate trust, which can lead to shared decision making and responsibility and ownership. So there wasn't, in George's case, that space to reveal that he had come to some decisions himself. That wasn't afforded to him. And potentially the communication was very one-directional. And he's feeling vulnerable in that space, even though he's well armed with the evidence and he knows what he's doing, or his decision-making. None of those cues were picked up. And so he wasn't afforded to have a voice. That would be my response.
Thank you. So just picking up that, what do we do better in that case? What is the fundamental thing for you, Varian, that the cardiologist should have done that he didn't do?
Ask what mattered to me. What were my hopes from this potential procedure? What was important for me to be able to do post clinical intervention? What was key for me in my life, and would this allow me to move towards that?
Right. So that's sort of fairly straightforward in a way, is that we have various options that we can discuss, but before we discuss them, what matters to you? That's what you're basically saying, isn't it? Yeah, fabulous. Okay. Would anybody else like to come in here? Well, I can see somebody else has put a long question in the chat, but Laura.
Yeah, I think I completely agree. Just something to put into the mix is that I did a few simulation sessions with undergraduate students, all of whom are incredibly well versed in person-centered care. Maybe not in the practice of it, but they can talk about what person-centered care is easily, and it's in every conversation. And what we did was create a multidisciplinary team meeting with virtual patients, gave an overview of the patients where the students had to make decisions about those patients' futures. Would they be discharged, yes or no? And we ran it very quickly, and we put a little bit of pressure on them to make a decision. And 100% of the times they made decisions without ever having an open conversation about, we should find out what that patient would want. So it maybe wasn't as simple as, will they be discharged or not, but there was no reference within the simulation about, I wonder what that patient might like for their own destiny. What might they like to happen? What would their decisions be? So that was never discussed. When we then had intervened in the simulation and spoke about person-centered care, about choice, about having a view on your own destiny, their decisions then changed. I then ran the same simulation at a workshop with very experienced professionals around, and the workshop was around values-based practice. I ran exactly the same thing with exactly the same narrative, and they did exactly the same as the patients did the first time round. They made paternal decisions about, this is what we should do. So it's really just something to put out there that when there was a little bit of pressure on, they didn't revert to that person-centered thinking being at the front of their minds. It was something that had to be added in, and therefore it wasn't their go-to place. It was an extra thought of, but I wonder what that patient would like to do. So it's just something to add into that conversation, that what is it part of people's everyday conversation of that actually what is important to you, what matters to you, where are your values, do they match mine or not? It's not that pastoral inquiry. And I'm not saying that doesn't happen, and I'm interested in what everybody thinks about this. Is it something that people are adding into their conversation, or is it their go-to place in conversation?
That's a really good point. You know, is it central? Is it part? Is it just an everyday normal part of being a good practitioner, or is this, which I got the impression of when we were talking earlier on, that you know, the guidelines, etc., that are offered to clinicians sort of do look a little bit like a tack on. I've found this in teaching ethics in medical environments for many years, is it's very often regarded as something separate from the actual decision, which is ridiculous, because it is the actual decision. But I wonder if that is part of the problem, and maybe the answer is to increasingly normalize that. Just make it normal to be honest and disclose and to engage in a sensitive way. So just to close, any final comments on this stage of our discussion before we move on to the next, from anybody?
Stephanie's hand is up, David.
I can't see hands, I'm sorry.
Oh, hi, David. Yeah, just want to come back and pick up on, I'm so delighted with what Verianne is saying, and Laura, it is this question about, what's important to the person. And I just want to make two distinctions here. I think from the point of view of the clinical gaze and addressing what needs to be addressed diagnostically or procedurally is obviously hugely important. But it's that important thing of separating out, that's health in one dimension, but then we have the very important aspect of health in the other dimension about what is good health to the person. And that's where that question becomes so important. And what doesn't get the same measure of importance around the clinical gaze, which really feeds often a culture cure at any cost, at what procedure is required for cure. Whereas how is the person going to live a good life where their health is good and they can do what they need to do? And that bit of what we do or can't do in our everyday life really determines our health and our health outcomes. And I think we need a bit of a recalibration about that, where that has to be rebalanced into the conversation.
Thank you, Stephanie. I mean, I couldn't agree more with that. It's not my role to do that, but fundamentally, it's always seemed to me that the problem is that the clinical world has a limited understanding of the nature of health. Health is a far broader concern to people. It's how you live, your autonomy, your quality of life, your existence, basically. It is not dependent entirely on what you do about a disease. And that has always been a very skewed perspective. I've personally tried to change it for many years and had no success, but well, limited. But really, I think that's it. It's not just about seeing the whole person. It's about considering their opportunities in life in a more general way than, okay, let's fix this problem. But fixing that problem does open up other potentials, but it can distort the focus, in my view. Well, it does basically. Does anybody else have any remarks they want to make at this point before I hand over to Laura again?